Well, Phil, what we're doing is a couple things with research, and before I go on further with it, I think one thing that's really important to note is the benefit of track. And this is a great example of what we've done with track, and I'm really honored and privileged to be a part of this, is idea generation. And what we're looking at this year came directly out of last year's track program. Well, one of the things we're looking at is the knee-ankle index, and can we affect it? And the thought process is that if you're lined up good over the knees, perhaps over the ankles, and they're not going into valgus collapse, it would be one indicator or potentially one thing we could look at that might correlate with reduction of ACL injury. There could be multifactorial, but that's a big one in the literature, as you and I know and have looked at. So what we're basically doing is, A, validating that as a tool. Is it something easy and clinically a person can do? In which case, if that's true, and I know we've talked at length about developing projects with this, if that's a true test or assessment piece, then we're using CLX band, and with the CLX band, we can now affect change there. But we wouldn't know, I guess in a simplistic way, we wouldn't know there was change in what we're doing if we didn't have a valid measurement tool to know we were in the first place.
That's right, yeah.
So we're sort of doing two parts. We're validating the tool itself to see truly what is the number or range we can work within, and then take people and train them with CLX and see if we can't change that number back into what would be more of a normative value. So real quick, what we're doing is we're going to have measurement, intervention with CLX, test it immediately, and then 90 minutes later, we'll check, which would be the equivalent of completing a practice to see if we can affect change.
All right.